Moving on to the last lecture of today. We have still 8 more lectures or 9 more lectures after today. So, yeah. I'll be talking about Radiologist in the Loop AI. And first, let me tell you a little bit about what we mean by Radiologist in the Loop. So, like we saw in the previous 2 sessions, if we build these models in silos, by that what I mean is we don't really consider the expert input, the domain input, domain expertise while building these models. The models will lack in some respect, some aspect when it comes to deployment of these models in the clinic. So that's why it's very important to make sure that these models are developed in conjunction with radiologists, with clinicians, or whoever the clinical stakeholder is, so that while the model is being developed, if there are bound to be issues that come up along the way, that the radiologist is there at every step of the way to deal with any of the clinical concerns that might arise. So, just a brief recap. We saw this clinical problem where we wanted to predict response to immunotherapy, right, where the first step was to get the segmentations of the blood vessels and to see what are these segmentations of where these blood vessels are that feed the tumor, and then extract features like tortuosity or some other twistedness measure or some feature to quantify the nature of the blood vessels, the morphology of the blood vessels that feed the tumor. Now, so what is the first step when it comes, so before even quantifying the blood vessels, what is the first step? The quantification is probably, it comes towards the end, right? You quantify it, you see if it's different between responders, non-responders, you build a classifier and do whatever you want to. But before quantifying it, what is it that you need? I mean, yes, you need data. So after you get data, what do you need? So you need, so by data, let's say you get enough data for the CT scan. So these are all CT scans. So you have the CT scan. So what do you need after that?
Determine the baseline parameters and how changes in responders versus non-responders, like the labels and the outcomes related to that.
So that's again the data. So
classification between the healthy individuals and the affected, to have a general overview of how like what is the what are the parameters in a healthy individual and how it differs from the affected one.
So when you say parameters, what do you mean?
Like the structure, the length, and the intensity, the density
of what?
Of the blood vessels.
Yes. So you need the blood vessels. How do you get the blood vessels?
Through different imagings, like different scans.
Anyone else? So this is a scan that you have, that you see on the screen. So these are the scans that you see on the screen. How will you get blood vessels from this?
The quality of the image. In short,
how do you get the blood vessels from these images? So all that you see here at the image, you see the 2 lungs, and you have some blood vessels dispersed in the lung. How do you obtain them? Yes.
We have to segment the image first.
Yeah. So you have to segment these images, right? You have to obtain these ground truth segmentations. You have to get these segmentations of these blood vessels. Now, we want to get these segmentations because we want to train a machine learning model to, we want to train the downstream model to learn what are the different aspects, what are the different characteristics of the segmentations. But we want to get segmentations first. And who gives us the segmentations? It has to be the clinicians, right? So the clinicians have to identify which of these segments or which of these regions are blood vessels, which of these regions are not. Because if you look at these CT scans, you will see that there are these airway tracts, right? These airway tracts might also look like blood vessels. So how do we first identify them? We need the help of a clinician. Now, if you look at an image like this, so if you remember the brain tumor image that we had, you saw that tumor and then you saw some necrotic region, enhancing region, and the peritumoral region. So that looked like one blob, right? But here, if you look at the blood vessels, if you look on the screen right here, you see the blood vessels, it appears so complex, right? It's a tree-like structure. There are probably, you know, tens of thousands of voxels. I mean, since this is 3D instead of pixels, these are voxels. Tens of thousands of voxels which are blood vessels. Now, imagine you want to sit with a clinician and you want to have them annotate every single pixel. It's almost impractical. No radiologist will have that kind of time to sit with you and give you annotations for these blood vessels, right? So, which means that we have to come up with innovative ways, we have to come up with smart ways to identify which of these or where the blood vessels are. How do we do that? So, this was a paper that we published in NeurIPS a couple years ago. On the top left, you see the ground truth blood vessels that were obtained. So, this was a challenge data set, and on the right, we had a model, we had an initial model that we used to train a blood vessel. We had these data sets. This was the parse. So, you can look up this data set. So, this data set has images and the corresponding blood vessels. So, we use this data set to train a first model or a baseline model that we can then use to predict where the blood vessels are on a given image. Now, we had this question arise at multiple points. What if your model does not do well in a test setting? Like you have new images, and you apply your segmentation, you apply your classification model, and your model for some reason it does not do well. That is fine, and that is exactly how we want to get data to fine tune our models. So, what we do is we look at, so you have certain regions on the left and the prediction regions on the right. If you look closely, you can clearly see there are these subtle differences in these blood vessel patterns. I mean, even though in a bigger picture it looks very similar, but if you look closely, you will see, you know, there are certain branching differences, certain bifurcations which are different between the ground truth and the prediction, right? And those are the ones that I have noted down on the bottom part of the screen. Okay, which of the regions you have these differences? And it's not just that one region, you see some regions. So, on the ground truth, you see that small filament on the left, and you don't have that filament segmented on the right in the predicted image, and that is what I am showing in the bottom image, that part that was missed out. So, you see that there are these tiny regions that we miss in our segmentation model, right? But these are the ones that actually become very important for us. But how do we decide, you know, which of these are important, which of these are not? So, there are techniques called uncertainty estimation algorithms, where we can estimate how certain or how uncertain a machine learning model is. Now, I am a machine learning model, I can predict an outcome, but I can tell you that, okay, I am 100% confident that my outcome is correct, or I am 10% confident that my outcome is correct. Like I believe with X% conviction that this is the real outcome, or this is the real prediction. So, machine learning model, you can actually quantify the uncertainty of a machine learning model. Now, we took a slightly, you know, different approach, where we computed the uncertainty, and instead of, you know, going to the clinician and telling the clinician that, okay, our model does not do well on the test case, can you please annotate all the vessels on the test case and we will retrain a model. Instead of doing that, what we asked a clinician to do was, we only identified the vessels that the model was uncertain, and asked the clinician, okay, can you please look at these uncertain segments and correct them if you think they are wrong, right? So, instead of providing hundreds of thousands of pixels to a radiologist, we only gave them what, maybe couple thousand pixels, right? So, that makes the job a lot easier, right? So, this is one way in which you can reduce the radiologist's time, and you then take the segments, you ask them, okay, this model, you know, this segment right here, which is highly uncertain, do you think it is correct, do you think it is wrong? If they think it is wrong, they will, we give them the functionality of changing the segmentation slightly, or if they think that is correct, then we just keep that in our training data set. Now, with the new segmentations or these refined segmentations that we get from the clinician, we can fine tune our model in an adaptive learning setting. We can keep doing this again and again till we are happy with our model. Okay, so what this means is we don't have to retrain a model with the same scale of data. We can retrain and fine tune our models with much lower data. So this is one of the active learning paradigms that we can use with uncertainty estimation to make radiologist's job much easier. So, and you see how by doing this we are actually keeping the radiologist in the loop. They know what kind of errors the model actually makes, right? It's not like we train our model, we give the model to the radiologist and say, okay, hey, test this in your clinic or deploy this in your clinic. During the process of model building, they're involved in it. They know what kind, so maybe they, by doing this exercise, they might notice that the model does well on, I mean, I'm just throwing it out there, the model does well on vessels in the lower lobe and in the lower lung and does not do well on vessels in the upper lobe, right? So these are the kinds of insights that you can get by involving the radiologist during the model building. Is that clear? Okay. Okay, so now coming to a slightly different project that our lab is working on nowadays, we are trying to study the radiologist's eye gaze pattern while they read these images. Now, this is a modality, a very different modality that is relatively unexplored in medical imaging, and I'll tell you why. So radiologists or pathologists, when they look at these images, I mean, how many of you have seen an X-ray film, like an X-ray? Many of you, right? So it's like a a thin film, and you might have gone to dentists or maybe for other checkups, and they take an X-ray, they look at it with the light behind it, and they see what's there. Now, there is a certain way in which they look at these images. Also, I mean, nowadays you don't really have these X-rays. Mostly you don't have these, everything is on a computer screen. When you look at a computer screen, the radiologists don't look at it, or for that matter, pathologists don't look at it randomly. There is a certain method to their madness there. I mean, there are certain parts of the image that they look at first, then they move to another part, then they move to another part. So it's something that they have learned over time, right? So they have been trained. I mean, they have what, 4 or 5 years of MD or MBBS rather. After that, there's residency, there's fellowship, there's super specialization and whatnot. So over the years, they keep honing their skills and they learn. I mean, I'm not saying that if you are a radiologist, you are another radiologist, that your reading patterns will be the same. You will learn to arrive at the same conclusion with slightly different reading patterns. But that's something that you have learned over the years, and both of you are correct in your own way, right? So what we hypothesized was, what if we start understanding and learning how the radiologists make decisions? Like, can we track their eye gaze, and how do we do that? So here's the motivation again. We have a deep learning analysis which we saw, where you can apply deep learning models like UNet, Inception or whatever, and you segment. It can be for segmentation tasks, classification tasks, or we can have a radiomics models where we extract sub-visual descriptors like shape and texture and use them in conjunction with machine learning models for different kinds of clinical application. The rightmost side is where you have the radiologist's eye gaze maps. So here you have a radiologist sitting here, he is dictating something. You have an eye tracker that is mounted here. Okay. So this eye tracker, what it does is, so when the radiologist looks at a screen, they will be focusing on certain regions of the screen, right? So that the pupil will be focused on, let's say that, so let's say we are looking at this image. When I look at this image, I might first look at, let's say, the top left corner, and then I might change, I might say, okay, what's going on here, then I might come here, oh, okay, it's very interesting here, then I might zoom into that region, right? So similar to what you see in your phone. I mean, a lot of times, let's say there's an interesting picture that you have taken, and while you have taken the picture, you see, oh, there's someone photobombing my picture. Let me zoom in, let me delete that person, right? So a similar approach. It's not just one level of zoom. They zoom in, they zoom out, they pan. So, if you look at a radiologist workflow, it's very interesting. They have multiple monitors mounted, and each of these monitors, or on a single monitor, they divide it into different parts, and in each of these parts they have a different view of the organ. For example, for the brain or for any other organ for that matter, you have an axial view, a sagittal view, and a coronal view. So, depending on, if you're looking at from the top or from the side or from the front, right? So, you have different views, and all these different views give you different they give you complementary information. So, yeah, so while looking at an image, it's not just one level of zoom. They pan the image, they zoom in, zoom out, and based on all of that, they finally arrive at a decision. Is there a disease? What kind of a disease? Where is the disease, right? So, these are the high level decisions that they make. But the way they make the decisions, there's a certain way they go about looking at these images. And our goal was to capture the reading patterns of the radiologists. Okay, so this is work. These are actually two pieces of works that we published at MICAI and ECCV a few years ago. So this was led by my PhD student Moinak, who you'll be meeting tomorrow actually. So he'll be coming here to assist us with some of the hands-on sessions. So what we did here was we trained a human visual attention module, and that's what you see on the right here. So what we do is, and this was actually data publicly obtained from a data set called the mimic, the reflex data set, RIFLACX, which has mimic images, images from the mimic data set. So yeah, so this data set has images and the corresponding reports also, but also it has eye gaze data that was collected from multiple different radiologists who were looking at these images. Now, what is eye gaze? So eye gaze, like I said, wherever the radiologist is looking at on the screen, it would capture where their attention is. Now, so let's say that, so that there are two components, like two high level components to it. You have something called the fixations, and you have something called the saccades. So fixations are nothing but points on the image, or portions of the image, locations of the image where the radiologist fixates their attention. So they spend some time at one portion, then they go to another portion. They spend n number of seconds on each portion, on each point, and that's the fixation. Now saccades is, so let's say you look at this portion of the image first, and then your attention goes here, and then your attention goes here. So these lines that connect the first region of the image to the second region of the image is a saccade, right? So these fixations and saccades are very important information that you can use to learn how a radiologist is traversing their attention from one region to another, or how a radiologist is, or where a radiologist is focusing on for n number of seconds. So let's say that if you look at the so let me go back here. So you look at this image, you see how random it is, right? So maybe the radiologist starts here, goes to another point, then goes back and forth. If you look at how they look at this image, this looks like a very random pattern. But when we convert it to a heat map, and this is just representative, this heat map will probably look a little different. So you see that most of the radiologist's attention was focused on this region, which means that that is the time where they spent, that is the region where they spent most amount of time to make a decision, right? And this kind of information is very important for us, and this is not something we traditionally collect, right? And this is something that can provide valuable information for model training. That's something we wanted to use in this particular project. Okay, so what did we do here? We trained a module called a Human Visual Attention Module, HVAT. So in this module, we obtained the eye gaze points, we obtained the fixations, and we trained a teacher module, and this was a global focal teacher. I'll tell you what global means and what focal means. We trained a teacher module, which was a SWIN transformer. It was a vision transformer, a SWIN vision transformer, to understand where the radiologist focuses their attention on to arrive at a particular decision. And then So now there's a slight nuance here. In the training, we have eye gaze, but in the testing, we do not have eye gaze, right? Because in training, let's say you set up an experiment, you collect eye gaze data, but when it comes to deploying that model in the clinic, we cannot collect eye gaze. Why is that so? Any thoughts on why that's, we can do it, but we should not do it, or let's say the hospital won't let us do it. Why?
Like if we are following the same thing, then obviously like there is some new data points are there, because like whatever data our like model is already trained, but those are maybe different. Like
No, okay. So let me rephrase the question. So let's say that you are a radiologist working in a hospital. I collect your eye gaze data for training my model. Okay. So now I have my data. I have the images. I have the corresponding. I mount a eye tracker. I get your eye gaze data, and I have enough. I have enough data points to train my model. Now, the model is, let's say, to detect pneumonia. Okay. Now, in the testing phase, when you have another, when as a machine learning researcher, I get another image of a new patient, if I want, I can collect your eye gaze data while you are reading that image, but hospital won't let me collect the eye gaze data. Why?
I don't know.
Maybe there might be some patient specific information on the scans.
I mean, doctors can always look at patient information, right? That's fine.
No, because if you are using it to train models, so the confidentiality aspect of it.
No, we're not using it to train models anymore. So in the inference stage, like we want to test the already trained model on new data.
Okay.
So here there's the question of it's a legal matter, right? It's a liability, because in the testing phase, if you collect the eye gaze data from radiologists, what if radiologist has made a mistake, right? And that can lead to legal concerns, that what if you missed something, right? So because in training it's fine, yes, but for testing, if you collect data from radiologists, if eventually the radiologists are the ones who have to make a decision, and for some reason, God forbid, if they make a mistake, the responsibility basically falls to the radiologist on the hospital, right? So it's a liability concern. That's why we won't, or we cannot obtain eye gaze data for testing. So what that means is, we have eye gaze data during training, we do not have eye gaze data during testing, but we still want to be able to use the model that we have trained with the eye gaze data. How do we do that? We have another model called the student model, which takes as input only the image. It doesn't take the eye gaze as input, because there is no eye gaze in testing. It takes as input only the image and gives some attention, and you see that this attention is very different from the, so you have a teacher model which knows, or which has learned what the radiologist attention would be like. You provide this image, and it would essentially, the student model would be fine tuned based on what the teacher model provides you, using visual attention loss, and that is something. So instead of a predicted attention like this, the attention we would try to force the attention to look like this, right? So based on that, we can say to some extent that we have learned how to model the attention, even if there is no scan path, there is no trajectories, visual trajectories in the testing phase. So now there are these two terms here, focal and global. So what does that mean? So what we did and what we observed, this is again going back to the previous lecture, where we wanted to get this domain aware information, right? So one of the interesting observations was, when radiologists look at images, first they look at the global view. So they will not zoom in. They will look at the X-ray as you see on the screen here, and they'll sort of make a mental note to themselves that, okay, this is what the image is looking like. Probably, this coordinate, this part of the image has some disease, that part of the image is normal, blah, blah, blah. But then they start zooming in, right? Then they start zooming into the areas which they think is interesting, or which they think would be interesting, and start, dissecting what's in there and making some sort of observation and making the decisions based on that. So there's a global pattern and there's a focal pattern, or there's a global and there's a local pattern. And that global and local search strategy is something that we try to replicate using transformer mechanism. So we have swing transformers where you can essentially change the windows, you can change how much stride length you have and everything. First we look at a smaller window, then we look at a bigger window. So based on that, we learn the global or we try to mimic the global and focal search strategies of radiologists. So we see that so RAD-T stands for radio transformer. So this was one of the first models that was published where anyone has used, for that matter, the vision modality, which is essentially the eye gaze patterns to make decisions. Here we are showing some of the heat maps for pneumonia. So with human visual attention training, we had much better localization, and without human visual attention training on the top, we did not have good localization of where the disease is. So we had to compare against different baselines. So bunch of ResNet. So this was in 2022. So these are the baselines that we had back then: ResNet baselines, DenseNet, and different VIT baselines. We compared our model, which had this visual attention module with other models, and for the most part we found that, and this was for pneumonia detection, for COVID-19 detection. So there's a data set called CheckSpurt data set, and the chest X-ray 14 data set, which has 14 different thoracic diseases. So we wanted to identify each of the different thoracic diseases. And we had our own data set, the Stony Brook data set, where we trained our model on. So this was for COVID-19. So across most of the data sets, our model with the human visual attention training was found to be much better than the models that did not have the human visual attentions. Okay, so coming back to the generative AI for data augmentation. So there are a lot of text to image models. So in fact, if you look at DALL-E or ChatGPT, for example, you just provide a text and it generates an image, right? So these are text to image diffusion models, or text to image transformers for that matter. So you provide a text and these models would give you an image. Well, if you try these on let's say ChatGPT or Gemini or something, you will see that they are not there yet. You will see that those images, you can make out that those images are fake. They won't look that real. So there has been a lot of research going on, and there's a bunch of papers that have been published which take the text as a prompt, and then you can train a model to predict or to generate an image. So what we found was that if we take the text as prompt and also the gaze patterns, that can help in generating better quality images. So because maybe the gaze looks at some patterns or certain locations of the image which are interesting and more relevant, and when you provide that as a prompt to your diffusion model, so these are all conditional diffusion models. So if you're interested in diffusion models, the first step would be to learn about diffusion models, and then to learn about how you can condition a diffusion models using different kinds of conditioning strategies. So you condition a diffusion model with gaze, and then you see that then what we found was that if you do a gaze based conditioning, we can generate more authentic or more real looking images. And now we are extending that to 3D as well. The image that you see on the right is actually we are extending that to MRI as well. The image that you see on the right is a text prompt, and then how the text, just giving the text prompt, we can get a realistic looking MRI image. And we can use this for data augmentation, like I said, but there are other applications as well. Okay, so based on my interactions with some of you earlier today, I remember that some of you work on vision language models. Show of hands. Okay, one of you. Yeah. So what's the fundamental strategy that goes into, let's say, training of a vision language model?
So if we are using any kind of image to train the model, so after that training, one model can give some features related image related features, we can say, some feature points or features, and some text related points. After analyzing the image, they will generate some text. So something like that, like a multimodal kind of a output they will generate, like in
So
normal.
let's take a step back and talk about training a vision language model. How would you train a vision language model?
Okay, so for that one, obviously, like we have to give some like context, like takes
Sorry,
that
what?
like context text.
Context text to
Yeah.
text.
So
Okay.
actually, yeah. So actually, that is more important. Like in like along with the images also, like we have to provide some context text.
Okay. So let me try to contextualize that a little
Okay.
bit for you guys.
Yeah.
So I'm sure most of you would have used Microsoft Word or PowerPoint or a lot of these text processing applications. So if you include a PowerPoint image, if you include an image on your PowerPoint slide, you'll see that Microsoft will suggest some sort of a caption for that, right? Some automated caption for that. Now, how does it come up with that caption? That's because it has a VLM model that is running in the background. Okay, how is that model trained? So there are a lot of data sets, and this is changing over the years, but there are a lot of data sets where you have this image text pairs, right? Caption. So you will have multiple data sets where you have a dog or something, let's say a cat or a bird, and you'll have a corresponding caption, a cat playing with a ball, right? A bird flying in the sky, right? So there are multiple data sets which have paired image and text data. Now what you can do is, you don't just have to train your deep learning model or your machine learning model with just images, right? You can also have a language model that you can train with text data, right? So so it's very simple. So you have your images and you have your text, you have an encoder, right? So you train your image encoder and you get your image representations. You train your text encoder and you get your text representations. Now, how do you match them? You basically have some sort of a similarity loss where you say that images and texts coming from the same image will have high similarity, and coming from different images will have low similarity, right? So that's the simple idea, and that's how most of these models are trained, or a lot of, I think all of these models are trained, right? So that's the fundamental way in which you train a vision language model. So you have the vision and the text corresponding to the same data point. So coming back to what our friends, our radiologist friends do. So ultimately their goal is to generate a report, right? So they are not the ones who treat the patients. They will generate a report. This report will be read by, let's say oncologists, and the oncologists, or let's say the surgeons, they will be the one who will be recommending treatment for the patient, right? The radiologist will tell them, okay, this is the level of severity, this is what I see on the image, it's potentially this or this, but then their work is done. The oncologist will take the report and then say, okay, based on what the radiologist tells me, I think this is the preferred course of action. So eventually their work boils down to generating an informative report, right? So what we hypothesized was, we have that eye gaze fixation data that we saw in the last project that I mentioned, and eventually what they do is, it's not like they write reports, they dictate the reports, and so there's a speech to text converter which essentially converts their speech to text, and they have this beautiful, this concise report. So but when they dictate the reports, they are looking at certain parts of the image while dictating something, right? They're looking at some other part while dictating something. So essentially there's three levels of information here. You have the image, you have the dictation or the text, and you also have the gaze. So our hypothesis was that combining these different modalities of information will help us generate a report in a much better way as compared to just an image, right? So there are a lot of companies. So I was there in Chicago last month, and in November, last month. So there were ton of companies there, startups, which were doing nothing but automatic report generation. All that we're doing was give us the X-ray scans, we will generate a report for you. No one knew what's going behind that, if the radiologist's attention or anything is being used, but the models are doing quite well. So our hypothesis was these models can even be made better if we take into account the radiologist's gaze patterns. Okay, so that was the hypothesis we started with. Now, here's the framework. So we have a vision transformer which extracts the visual features. Then we have a scan path prediction module, which is an auxiliary task. So remember how we saw this scan path in one of our previous slides. So this is essentially where the radiologist focuses their attention on while reading an image. So like I said, it's almost impractical to expect a scan path to be collected in the inference phase. But we can train a model that can predict the scan path, right? And there's a model that we actually trained. It's a med-gaze model. We had to fine tune that med-gaze model. And what we did was we fused the image features, the gaze tokens, and the positional data basically via a graph neural network. And then this multimodal prompt that we got from the previous step was used to fine tune a large language model. So this was a llama model that we fine tuned via a LoRa adapter. So here's the data. And some of you might find these data sets interesting. These are all out there. So if you guys want to use data sets to get your hands dirty with training machine learning models, especially which has imaging and text, these are some of the data sets. So Reflex data set, it has images, it has eye gaze data. The Indiana University X-ray data set, it has images and it has reports. So reports are a very rich source of information because they tell you, what that image has in the language of radiologists. And there's the Mimic CXR data, which again has images and the corresponding reports. So we used these data sets to train our model and to generate the final report. Now, for those of you who, I won't really go into details of this, but for those of you who are interested in NLP, natural language processing, some of the metrics that are used in this particular domain are BLUE score, Meteor score, and Rouge score. So these are not accuracy or AUC or anything. So these essentially look at how good your prediction is when you consider, let's say, 3 words together or 4 words together or 5 words together, right? So it looks at that kind of reasoning. But then there's another very interesting and important lesson here. These might be good metrics for evaluating, let's say, general purpose report generation or general purpose text generation, right? So for example, let's say you ask your GPT, your favorite transformer, your generative model to generate something for you, and you would evaluate it based on how good it looks like based on what you expect it to generate, right? So if the language looks similar to what you are expecting, then you give it a good score, otherwise you give it a bad score. But this is very different from what a clinician would expect. They don't expect the English semantics or the sentence construction and all of that to be correct. They expect the clinical accuracy, that certain terms regarding what the disease is should be correct, right? It doesn't have to be in flowery English language or the way Shakespeare's language would look, right? So it has to be something that is grounded in clinical factuality. So that's what clinicians would expect. So there are metrics such as precision recall or F1 score that you can use at a disease level to identify or to evaluate how good your language model is. So by doing that, we actually saw that compared to all of these different models, our gaze to report model was able to generate better reports because it actually saw the eye gaze of radiologists, but the other models don't really see the eye gaze of the radiologist. And this was found to be true not just for these metrics, these NLP metrics like BLUE score, Rouge score, but also for the clinical efficacy metrics that we just discussed. So it outperforms state of the art on the 2 different data sets that we saw. It improves scores across the board, and it's better than most of the baseline comparisons that we had. Okay, so here's an example of what is actually generated. So here the first column here is the first column of text is the ground truth data. Then the second column is where you do not have gaze, right? So it's a baseline model where we do not have gaze. It's an image only model or image text only model. And then if we have gaze, if we train a model with gaze, these are the reports. And we clearly see, if you look at the generated reports, you'll see that that our model has a lot of clinical factual correctness in it as compared to the model that did not have the gaze. And I'll provide you the slides. You'll see how the different terms that you see here in the gaze to report match a lot better with the ground truth as compared to the model that does not have gaze in it. Okay, so we did a few ablation studies. So the first ablation study was the takeaway from the first ablation study was that our model outperforms methods that leverage gaze at inference, and that the performance in gaze-free setting is still strong due to scan path prediction module. So even though we do not have gaze in the inference stage, because we have this scan path prediction module, this module helps us predict or generate the reports in a better manner. Okay. Now eventually we would want this to help clinicians. So why would this matter to radiologists? So a lot of times if you look at AI generated reports, they miss different key findings, and these key findings are usually actionable, right? There can be small lesions that the reports have missed. So we want to be able to reduce these key findings which would otherwise be missed. Second, there's a poor alignment between image evidence and text. So if you look at these reports, a lot of times these come as summaries, right? So it's not like they say, okay, here's what's happening at coordinate 1,1, here's what's happening at coordinate 1,2. Reports are not that detailed. They will tell you, okay, this is the image, this is what the disease is because of these findings, that's it. But gaze data is very detailed, because you actually get your fixation data. When you construct a heat map, it tells you where the radiologist looks at, which portion they focus on. So it's a very granular level of data, right? So if you can use gaze to ground the report information and the image information, that gives you it gives you a richer source of information correspond to just image and text alone. So the goal is to embed these human priors in the form of gaze into the generative framework. So we spoke about radiologists. Tomorrow we'll be talking about many of the projects in digital pathology, but here's an example of, okay, sorry. So here's an example of what can be done and what one of our other group members has done with digital pathology. So what they have done is they want to take these images. These are all pathology slides that you see here. These are digital pathology scans. So essentially tissue that has been taken, and then traditionally the pathologist would look at it under the microscope, but you can always digitize it with a high powered camera. And then instead of looking under the microscope, pathologists can look at these images on the screen. They can zoom in, zoom out, they can pan, and whatever they want to do with the image, and they arrive at their decisions. So while the pathologists were looking at these images, they collected this data as scan paths or as viewing patterns on the images, and then what the model that was trained, this was presented at ISB a couple years ago, they predicted the attention heat map. So this is what they predicted. This was the real heat map, and you can clearly see that it tallies quite well, it matches quite well with the real heat map. So what this tells you is, you can actually train models to predict where the pathologist will look at next, right? So you might be wondering, where can this be useful? I mean, yes, for the we saw how it can be useful in improving machine learning models for, let's say, disease classification, like we saw in the 14 different chest X-ray diseases. But what else? Where else do you think a gaze prediction module and attention prediction module can be useful clinically?
Sir, as an like weekly supervised thing we can use, like where like there are very less amount of data are available, but if like not less amount of like level data are available, but for unlevel data we can provide some weekly supervised like those kind of heat maps.
Okay, so you are approaching it from a machine learning perspective. Why don't you think like a clinician? Where do you think they can find this useful?
Maybe sir, like those attention map will help them to just to like to generate some initial like results or findings mostly. Like
I think yeah, you're getting there. Anyone else?
Maybe these algorithms will help them show them where to focus.
Good. So it can be used as a teaching strategy, right? So so think of it this way. So when radiologists or when clinicians are trained, it's over multiple years, right? You know, you have senior attendings, then you have junior radiologists, junior fellows, and so on and so forth. But it's very difficult for, let's say, to have a teacher at every step of the way. But if you can understand what a teacher is doing, right, and then when a student is making a mistake, if the teacher can nudge the student, and in this case it's a machine learning, it's a machine learning model. If the machine learning model can nudge the junior radiologist or the junior pathologist to say that, okay, you know, this is not here. Maybe try to move your attention a little bit up north or a little bit down south. Then it can be used as a teaching method, like as a training strategy, right? So a lot of times, so let's say that, you know, what we can do is there's this session, or there are over multiple sessions, junior doctors learn how to read an image. Maybe you can have an evaluation session where you look at their eye gaze, you give them a bunch of images, you ask them to make a diagnosis, but you record their eye gaze, and the doctor actually then or the senior doctor looks at how their eye gaze is changing, right, and tell them, okay, you should slightly change your search strategy because what you are doing is not leading to correct answers, right? So something like this can be done if you can record your eye gaze, and also if you have a machine learning model, it can help in it can help in you know, understanding where the person is going wrong. Okay, so just switching gears a little bit, I'll talk a little bit about diabetic macular edema. I know that a bunch of you here are working on diabetic eye disease. So probably in diabetic retinopathy, but a related disease is diabetic macular edema. So what happens in diabetic macular edema is you have a retinal thickening of the center of the macula, and this results in, you know, loss of vision. It emerges from DR. It's a complication of type 1 and type 2 diabetes, and the prevalence of diabetes it's expected to double you know, by 2030, which is obviously very concerning. So what's the pathophysiology of DME? So hypoxia within the eye, it can lead to an upregulation of VEGF, right? And when you have an upregulation of VEGF, what happens is your vessel walls start weakening, and when your vessel walls start weakening, there is leakage that happens out of the vessel walls, and this can alter the permeability of the blood retinal barrier. So, you know, the lack of proper filtration system due to these damaged blood vessels, they can lead to the buildup of the fluid within the macula, and this is basically what happens in DME. So the unmet clinical need here is that we need prognostic non-invasive imaging markers that can help identify patients that need anti-VEGF treatment, okay? And we want to do that before the treatment is administered. Like it's a similar sort of logic to what we had in immunotherapy. These treatments can be very expensive. So what if we can identify who are the patients who will respond to treatment, who are the patients who will not respond to treatment before the treatment is given, so that the doctors can identify who are the right candidates for the treatment. Not just that, if you remember, the second part of the question was, can we monitor if the treatment is working or not? Okay, so here's the timeline that you see. You have the disease diagnosis, then you have different kinds of therapy, and the therapy that we are talking about here is the anti-VEGF therapy, and you want to assess disease progression. So we want to see if at this point we can make a decision whether the patient will respond to therapy or not. So, this was the data that we used here was part of a clinical trial at Cleveland Clinic. This was the Permeate clinical trial, where the patient was, it was a prospective study. It focused on treatment naive eyes with, foveal involving edema. It was secondary to DME. The drug, the anti-VEGF drug that was given was aflibercept. It was given for the first 6 months. So, first we had the image that was taken here. Then the drug was given, then another image was taken, the drug was given again, and then we had the clinical determination of visual acuity, whether the patient's vision improved or not. So, this was the eligibility criteria. I don't really have to worry about this, but the images were collected over a span of 12 months. The modality that we used here is called UWFA, ultra wide field fluorescent angiography. So, this is a modality that helps you look at the morphology of the blood vessels. So, here is what it looks like. You had, so this, there are two different kinds of information here. The first information that you see here are the blood vessels. You have the blood vessels, baseline means before treatment was given, and that's what you see here. And then you have images that were collected after month 1, images that were collected after month 4. And we have images for non-responder cases, a sample non-responder and a responder case. So, that's the vasculature information. We also had information regarding where the leakage areas were, right. So, that's where the fluid deposits. So, the hypothesis was that we can study, similar to what we had for the lung, that we can study the blood vessels in these UWFA scans, and the morphology and the arrangement of the blood vessels will help us decide who are the patients who are the optimal candidates for anti-VEGF, right. And it is not just the blood vessels, we also want to look at the spatial proximity arrangement of the leakage patterns that you see on the scans. So, interestingly, when we looked at the spatial proximity patterns using graphs, we found that rebounders, so non-rebounders are the responders, rebounders are the non-responders. We found that the way these leakage patterns are arranged are very different for the non-rebounders as compared to the rebounder, and this can be used as a feature in your classification model. So, similarly, so in fact, the takeaway from here is that on the baseline scans, the leakage patterns in the non-responders was less chaotic when compared to the responders. And similarly, for the retinal vasculature network, we found that the non-responders had sort of a more chaotic arrangement of the vasculature as compared to the responders. So, this was also observed using, I believe we used a random forest classifier here. Using the classifier, we found that the AUC was pretty good for identifying patients who respond to the intravitreal aflibercept. So, the takeaway from this experiment is that on baseline UWFA scans, the non-responders had a much more tortuous vessel network as compared to the responders. So, the next part of the experiment was to look at how the vasculature changes. So, similar to what we saw in the lung slides, you had images that were taken before treatment and then images were taken after treatment. And we know that a drug like anti-VEGF therapy aflibercept, it changes the organization of the vessels, and that's exactly what we found. So, after 4 cycles of anti-VEGF, we found that the non-responders had a much higher change, to the nature of the blood vessels as compared to the responders had a higher change compared to the non-responders. Okay, so that was some application in ophthalmic imaging. So, we also have recently started work on dental imaging, where, so this is a recently funded grant, where we are looking at cone beam CT scans, and these, using these CT scans, we are identifying where you have different calcifications, and we have shown that the nature, the morphology, the texture of the calcifications are actually related to cardiovascular risk. So what this means is that, a lot of times you have these scans that are taken by your dentist, and they don't really, bother much about if you have, what these calcifications mean. But if a model like this is successful and eventually is deployed in clinic one day, a dentist could actually read your images and tell you if you are at a higher risk of heart attack or not, right? Because you have these calcifications that appear at different zones, and these we have shown in a very preliminary study of 120 cases or so. We are currently expanding it to more than 300 cases, that these are indeed related or associated with the cardiovascular risk. And here are some of our before I go to the results, you see the calcifications here, and we have different kinds of calcifications. These are the ground truth calcifications, and these are the predicted calcifications. So by looking at the calcifications, do you see any kind of, do you observe, or do you think there's any challenge that machine learning models might face here in order to identify these calcifications? What's different from this and what you have been seeing so far with other images, let's say vessel images or brain tumors?
Perhaps the feature size is very small,
Yes,
hard
yes.
to detect.
Hawkeyes, yes. So you have really small calcifications here. So just look at how big the image is and how small the calcification is, right? It's probably less than, let's say, 0.1% of the total number of voxels in the image. Now this is very different from what you saw in the lung vessel work or with the brain tumor work, where the objects of interest were considerably larger. So it's probably a little bit easier for the machine learning models to, or the segmentation models to segment those primitives as compared to this, and that is exactly what we saw here. Our prediction performance, our segmentation performance wasn't that good. So our DSC, or the dye similarity coefficient that we use to segment, that we use to measure how good the segmentation models are, were quite low. They were about 65 or 70% here, compared to what we saw in the brain images, where we were close to 90-95%. So we are still working on developing techniques that can help us improve the segmentation of these low size lesions. But here are the results of cardiovascular disease classification, and the different events that we had were stroke or other cerebrovascular accidents, heart attacks, myocardial infarction, and we found that if we combine again radiomics with clinical features, our results were much better as compared to just clinical features or just radiomic features. So this tells you that there is a certain degree of association between your morphology and texture of the calcifications and cardiovascular events. Okay, so finally, it's since I have to summarize what we have learned over the past hour or so, the goal here is not to have radiology AI as a standalone system, but we want to augment its intelligence with, we want to augment radiologist intelligence with different kinds of AI methods. So it's the augmented intelligence that will be the next frontier in health imaging. So I think I briefly brought this up in one of my previous lectures earlier today, that there is this rising concern amongst new trainees, amongst upcoming radiologists, that radiologists, that AI is here to take their jobs, right? But that's not what's happening. That's not something that will happen, at least in the next 100 years, right? What AI will do is probably make the job easier. It'll make the job faster. It'll come up with new triaging mechanisms and have them, eliminate the need for mundane tasks, so that the high priority tasks can be assigned to radiologists. And also, there are no extra, so there's a huge demand for radiologists, right? So nowadays you have situations where you don't have enough radiology, you don't have enough specialized radiologists. So if AI can be used in a way that can help alleviate some of the burden of the radiologists, that can actually help in improving the clinical workflow by leaps and bounds. In fact, it's a cliche nowadays, but radiologists who don't understand AI will augment radiologists, augment those who understand AI will augment those who don't understand AI. So that's what's happening or what will happen now. So with that, come to the end of our the first 3 lectures where we covered different aspects of radiology informatics, AI models as they're used in radiology. To summarize, context or clinical knowledge, domain knowledge is very important, and it's always necessary and desired to involve your clinical stakeholders like radiologists in every aspect of the model building, so that they understand where the model is right, where the model is wrong, what needs to be corrected, so that you can try to, or you can design your fine tuning methods, your active learning methods accordingly. Okay, so I'd like to thank all my lab members and funding agencies, and yeah, any questions?
Is there any like particular approach to deal with like very small ROI for segmentation? Because I saw like you are also telling the same thing. Like it is very difficult to segment those parts. So like, is there any particular approach that we can follow?
So some of the approaches that I've seen are, so basically when you have your loss functions, you can have something like a focal loss,
Yes,
Seversky loss or something. I don't
like
exactly
focal
remember the name.
losses, like, yeah.
Yeah, so you can have those losses. I don't know. I mean, that's something we are working on. I don't know if there's people have tried multiple different approaches, looking at it at multiple different scales and trying to see if that solves the problem, or looking at it with respect to the other organs or the other landmarks that are around it. For example, if that can solve the problem, some graph-based approaches. But yeah, I don't know what solution
So like,
to that is.
sir, like, can you do something like, see, like, we knew that like that particular portion is like we have to segment.
Right.
So can we crop that part and then we can fade those part to the image low?
So crop that part and do what?
Like crop that part from that image and then we can feed like that cropped part
Okay.
to the model, and then like we can tell the model to segment. So this is the right approach to follow, or?
So, but if you do that, so okay, so think about this. So if you do that, you will have the cropped region where you have the calcification, this small calcification,
Yeah.
but you also have to give to your model patches that do not have calcifications, right? You will crop it, but then there's this data set imbalance. You will have more patches that do not have calcifications, because that's the that's the domain you're dealing with, right? You'll have order of magnitude or multiple orders of magnitude more patches that do not have calcifications than patches that have calcifications, right? So which means your data set is highly imbalanced, which means you'll have to bring in losses that can counter this imbalance, or you have to do some artificial augmentation of these low representation patches. So that's something you have to do,
Okay.
right? Yeah.
Thank you, sir. Thank you.
Sir, I have a very basic question. So, sir, first I want to know, like you told about the gaze pattern of the gaze and all. So, sir, I want to know that for every human being, because the radiologists are human beings. So, every
Yes.
human being, the vision pattern, like this is a concept like 6x6 vision or 12x12 vision. So, the vision are different for different person and different human being. And also the light intensity, in that case, those things will also come into consideration, the light intensity, the amount of time that person is looking, what you already told, the contrast of the monitor of the
Right.
computer monitor.
Yeah.
So it is not like that, like it is more machine oriented than human oriented. Can you like
Yeah.
tell
So
me?
that's a very good observation. So what you're trying to say is that there's a lot of variability, inter-subject variability, right? So radiologist 1 will have inherently different vision, and then maybe the monitor that they're using to visualize these images will be slightly different from what radiologist 2 uses, and that's a good point. And that is why this data set that I mentioned, the reflex data set, has eye gaze collected from multiple different radiologists. So if we have a paradigm like that, where the same image is investigated by multiple radiologists, presumably on multiple different screens, that can help us counter some of that variability. But what that means is also that we have to come up with a module that combines the 5 different gaze patterns to come up with one consolidated gaze pattern. So that's something that we have done in one of our papers, actually. Yes.
Thank you so much, sir.
Yeah.
Sir, we have talked extensively about this MRI modality. So,
Yes.
one more thing I'd like to add, like in real time in RGB modality, like if you take some smartphone images, something, and so in that case, like when take images, there's some reflections coming. Like if you take like endoscopy images or like a smartphone image. So to deal with that, is there any specific studies? Because we can separate the channels and train. That is one option, but
Yeah.
we lose information in that case. So what are the options in that scenario?
So, again, I'm not really familiar with what are the different pre-processing techniques when it comes to the kinds of images that you mentioned, with RGB images in the in dermatology. You have a lot of data sets where patients click the images of the lesions and upload it, right? So obviously the kind of the camera that you use and also the lighting conditions, there'll be a lot of reflections and stuff. So one of the since obtaining these images is relatively easy, one of the ways to do this is through multiple different augmentations, right? You color jitter it, or you do different crops and whatnot, and then you provide it. But I don't think there are any traditional pre-processing approaches that are used to handle any of this. Maybe with the endoscopy images, maybe there's some algorithms that can help you reduce some of the glares that you see there, but no, I'm not sure.
Okay, fine.
Yeah.